Some knowledge of surface marking of the things you can appreciate. If someone, patient will never come and say to you, doctor, I have a thyroid problem. He will tell you something different. And when you really go for it, you'll find something different. Excuse me, you have some special issue? I'm observing you for the last 5 minutes. Now, here you can see the hyoid bone, and down you can see this blue thing. I'm sure it's labeled already, is the thyroid cartilage, and down you can see this cricoid, and this pinkish thing, this reddish thing is the thyroid gland. Now this thyroid gland, for anything, we need to have a reference, we need to have a level, because now it's an era of MRs and CT scans and all these things. Cross-sectional anatomy, the knowledge of cross-sectional anatomy is very pertinent to understand these things, because if you are given a CT or an MR, how you will able to make out at what level it is taken, maybe it's given, but then you should be knowing what organs are living at that pertinent level. So to meet that requirement, you should be good with some perspective of trans-sectional anatomy. So in that regard, what is the extent of this thyroid gland itself? So, any idea? T something. What is T? T4. T for tiger? Now the two thyroid lobes, they are connected by a common stalk which runs transversely, and that's called the isthmus part of the thyroid. And the level of that one is second, third and fourth tracheal rings. This is where this isthmus is present. And then we have the lower limit of the thyroid. It corresponds to sixth tracheal ring. Sixth tracheal ring is not C6. Sixth tracheal ring is the lower limit, normal lower limit of the thyroid. I'm talking normal lower limit. Now this normal is variable. If you take normal for Africans is different. Normal for the South Asians is different. For different nationalities, different areas, it's different according to the size, shape and general structure of someone. For each people, their norms are a little different. Anyway, so the lower limit, it corresponds to the sixth tracheal ring, and the upper limit. On this thyroid cartilage, we have an oblique line. So that oblique line is the place below to that. We have the beginning of the lobe of this thyroid, and down we have, this is where it usually ends. But normally, as I told you, this is a movable organ. It is attached, it is covered by fascias. It has a true capsule and it has a false capsule. The true capsule is the condensation of its lining connective tissue, and the false capsule is derived from pretracheal fascia. So it attaches with that, and the posterior part of that fascia, it becomes thick, and this trachea and this fascia is attached to the thyroid cartilage, and down it is attached. So by the movement of hyoid bone, so by the movement of these structures, because they move during act of swallowing, so this gland also moves. That posterior thickening of this thyroid fascia is called, its name is ligamentum Berry something, and this Berry is very important. While you are operating on a thyroid, you have to identify it and you have to divide it. Okay? One has to be very careful with that situation. But anyway, this is the extent of the lobe of the thyroid. If you look at it, the upper lobe is more conical and the lower lobe is bit broad. And both of these lobes, they are connected by a lower down thing. So it is a gland which rests in the lower part of our neck, and they are two in number, but they are connected by a common transversely going isthmus, and that connects the two lobes of the thyroid gland.
Why would the surgeon divide the ligament?
Because you have to take the extent, and there are so many things involved that underneath there are vessels. I'm not supposed to cover the surgical technique. If you want, we can talk extra. Okay, over a cup of coffee outside. Feel free. Now, as I was telling you, there are certain levels where we should good about things. So these lines, you can see, we have different places like C3, C4, C6 and T2, T3. Who was saying something T? So this is where, so these levels are important, and there you can see what's happening here. C3 is the level where you can find the hyoid bone. C4 you can see this thyroid, and this notch is corresponding to that. C6 it's a very common place. I'll talk about that. I have a list of events which are occurring at this place. And this T2, T3, this is where the suprasternal notch, and T4 is the level where your trachea it bifurcates. Yeah. So these levels are important. I've explained about that. So these are important for cross-sectional anatomy, and you should be knowing about what is happening at which place. So if you are in a situation, if you see a trauma case and you are looking at, so you can easily make out, oh, hyoid is gone. So the injury is at that level. So you can really decisive of, you are knowing of what structures are at risk at that pertinent place. So now there is a very important landmark. The lower border of the cricoid is an important level in neck. It corresponds not only to the level of the 6 cervical vertebrae, but it also to these all things are happening here. The larynx becomes trachea, pharynx with the esophagus it joins level at which inferior thyroid artery enters the middle thyroid vein, leaves the thyroid gland, and then you can read it all. So all these events are occurring at this particular point. So this level is very, very important. If someone has some injury, some issue, some problem, so one should be very careful, and you can see what sort of transition is going on at this particular level. It is important. Well, you'll get it on Moodle, no need to write it down. Now, let's come to our real business, what we have talked about. You can see that you are appreciating now, this is the upper lobe, this is the lower lobe, this is in between the isthmus. Now what is this? This is the pyramidal lobe. It's not necessary that it should be there always, but it can be there. If you are operating on, if you are palpating upon a thyroid gland and you will feel something going in the middle line, don't be confused. Okay? Because this neck swellings in the midline and laterally, they are very important part, and I'm sure when you'll be doing the examination of the neck, you have to remember one thing. Whensoever you are asked to examine the neck, and especially the palpation part, you should be standing behind to your patient. You shouldn't start from the front. You can do inspection, no problem. But when you are palpating something, when you are examining thyroid or some lymph nodes or something, you should always be, your patient is sitting. It's not like he's standing or she's standing. Patient should be sitting on a comfortable seat, and you are standing behind, and then you are palpating up everything. This is a very important thing, and usually people, they fail in different level of their residency exams or all that.
What's the purpose for palpation from behind?
This is a standard way.
So it's better to...
It is always done. Like when you are examining a patient, it is always said, go on right side. 99.9% examination are done for GI, for abdomen, are done from the right side. When you are doing your round, you will see your doctor, your chief, he always go to the right side, and from there he or she start his examination. There are certain standard procedures. Why? Okay, if we go into the whys, there are so many reasons maybe, but at this level it's not your concern. When you will be at this level, then you can go into these details. Is this clear? Now this gland, we are talking a lot about that. Underneath and overneath, we have so many muscles. So I like to see how this gland look like in a section. Now this is how it looked like in a section. There you can see, if you orient yourself, in front of this we saw this anterior jugular vein, and there we have this set of muscles. You know them better than me. Sternocleidomastoid, sternohyoid, thyroid, omohyoid, and all these are here. External jugular vein is located somewhere here, and there you can see this is the gland, and it is enclosed in this fascia. And now you can see this is the larynx, this is the trachea, and this is the esophagus. This trachea is always open because there are C-shaped rings, cartilages, and the purpose is this air tube. If this collapses, how the gaseous exchange how the passage of the air is possible. So to prevent any such thing, this has to be patent all the way. And just posteriorly, because C is never complete. So just its posterior limit, who is residing here, a collapsed tube, that is esophagus, which is a fibromuscular tube. Only when bolus of food passes or some water passes through it, it opens, and with the help of the peristalsis, because for air there is no peristalsis. For the food thing, for the GI part, we have the peristalsis. So food moves when it opens. Now there are two very important structures which are sitting right in the sides. They are recurrent laryngeal nerves. And when people have problem with the thyroid, the very common problem comes hoarseness of the voice. And there are reasons to that. So recurrent laryngeal nerve is a very favorite of head and neck surgeons who are doing thyroid operations. And their first and foremost important task is save the recurrent laryngeal. And some of them who are not cautious, they take this recurrent laryngeal, and when it's gone, then you can see how your vocal cords behave. So it's very important now, before any thyroid surgery, they do an ENT evaluation of folds and everything, recurrent laryngeal nerve is working or not, and after completion of surgery, the test of the surgeon, if patient survives and everything goes fine, look for the recurrent laryngeal.
For the tumor of the thyroid, compress the...
Yeah, there are so many possibilities, so you have to save them, no matter what. Because tumor, you cannot take the whole disease away. You can take the macro disease, but micro disease stays there. For that purposes, you're subjecting your patient for chemo or radiotherapies. So now this section, as I told you, this is at C6 level. And just behind, you can see this carotid sheath. And carotid sheath, the innermost structure is these common carotids. Then you can see this vagus nerve, and this is the internal jugular vein. You have seen anterior jugular vein, you have seen external jugular vein, and you have seen internal jugular vein. And just behind, what are these? Sympathetic chains. Vagus is in between. Vagus, you will find within the carotid sheath, in between these two vessels. And this sympathetic one, it goes behind. It's not within this vicinity of this carotid sheath. And this is the prevertebral fascia which goes on the back. Is this clear?
Yes.
Why this is important? This is the reason. Because you are not giving any such thing in your lifetime. Patient will never come a picture with like this. He will come something of this sort. And there you are asked to identify. And exactly everything is there. But now this is our test to interpret our knowledge onto this area. And that's the important part why we are focusing on to this cross-sectional anatomy part. Now, simply this is a system where you can see this thyroid cartilage, thyroid gland, and then the trachea and esophagus are shown. This is from the front, this is from the behind. And you can see. And can you see these four tiny things? They are parathyroids. Look, they can be. These are small, different colors to them, bluish, grayish, and golden color and yellow color. So many colors are named to them. They are variable. They can be from 2 to 6. So it's variable. And they have their different positions. That we'll talk tomorrow, why that will happen. But if sometimes it's very, very important when you are planning for, there is some problem with the parathyroid and you have gone in to operate on those parathyroids and you are unable to find them. Then there are different methods how to identify them. You are injecting some contrast things, some markers and all that, and then it's difficult at times. Sometimes it's very easy, they are quite visible. You take them out. But if they are ectopic sites, like away from the normal site, then you are in trouble. So, at the moment, I have a little more concern. So, I have a section here. Again, the same picture. The section, it reveals something like this. So, now this is a section where it has gone through the isthmus part. So, you can see all those structures which you were talking. Now, the same structure magnified, the same section. And this is a CT. It's not through the isthmus. And this is an MR. And there you can see, this is how these patients will come, or if there is a tumor, you can see a growth arising from this.